So just to remind a little or to let the people know a little, we had this, the Libby Epidemiology Research Program, which was the grant that we had from the ATSDR grant for 5 years, which many of us are part of it. And it had 3 components. One component was the pre-adult latency study, which objective was to evaluate the malignant and non-malignant health effects of exposure to Libby amphibole that occurs during childhood or adolescence when the lung is being developed. And we published a paper on that that had very interesting findings. Then there was the second project was the autoimmune outcome study, which we've been talking throughout all these couple of days. And that's an ongoing, as you can see, from the talk, it's an ongoing field of research because we think there's a lot of future there. But this was really the seeds of that project. And then the third project was the CT progression study. And the objective of this study was to evaluate whether the rate of progression of pleural and or parenchymal changes in Libby were significantly more rapid as compared to other types of asbestos. And in order for doing that, we had the ability to have this group that we followed at Sinai at that time that were asbestos workers that work mostly with commercial asbestos. Most of it is chrysotile, may have some contaminations of little type of asbestos, but it was most of it chrysotile. So we had the opportunity to really compare not only in the mouse and in vitro, but also in vivo, in humans, let's say, no in vivo because the mice are alive. So in humans, the effects of these 2 types of asbestos. And this is what I'm going to show you today, some very preliminary and very early data of this project. This project was, we never got to complete it. So maybe it's time to, we can revise it and see where we are at. Before doing that, I just wanted to stop a minute and, Gino already mentioned Dr. Levine. He was the initial PI, and we were talking with Aubrey yesterday. I'm sure he is here with us, and he would be very proud to know that we have continued this effort. And it's all in his memory. He'll be with us always, as the slide says. This was our original team, and thanks are never enough to all the people. This was the car people from the original. Some of them are still around. Some of them have moved to different venues. And this is our people from Sinai, from Kalispell, many of whom are today. And it was for me a tremendous opportunity. And really, I'm so thankful, to have met and worked with these people as extraordinary people doing extraordinary things. So thank you, to everybody for that. So our CT progression study had 2 hypotheses, and they were all based on clinical observations. We came from the clinic, and the clinic is mostly Brad's experience. He talked to Dr. Levine, and we look at many x-rays and all of these examples. You see how excited he gets when he shows these cases. I was telling to my wife that Brad knows these patients from, you see the CT scan, and he knows what patient it is. He knows the patients from the inside out, literally from inside out. We had 2 hypotheses. One was that even low environmental exposure to Libby amphibole would result in greater abnormalities than heavy occupational exposure to chrysotile. And this to me is really a hypothesis that is against everything that we know. You try to compare people with low exposure against people with high exposure. It's really going against all odds. And I think one of the interesting things of this study is that really was planned to go against the most logical things. You want to say, well, I want to compare people with high exposure to high exposure, but here we're comparing people that are very low with the very high. And we're still thinking the very low are going to do worse than the very high. And it's one of the beauties of this idea. It can be a criticism as well. So that's one of the things I would like to explore at the end. The second hypothesis was that the Libby amphibole results in accelerated degree of clinical and radiographic progression as compared to chrysotile. So how did we plan? How did we do it around, or what we had planned? The idea was to compare clinical, radiographic, and functional pulmonary abnormalities in a group of Libby residents exposed to Libby amphibole only environmentally, with former workers exposed to chrysotile. And we say only environmentally. We really wanted to get people in Libby who were not even sharing their household with somebody that worked in the mine. We went to those, that degree of requirements to have really the people with very, very low exposure. One of the problems is that the Sinai cohort were mostly men or all men, so we needed the Libby cohort to be all men. So this is a study, it's not discrimination, it's just the way world worked at those times. Men were doing the work. So this is a study all done in men. We required everybody to have more than 15 years of latency to make sure there's enough time for asbestos changes to show up, and to have an abnormal CT scan in order to enter the study. We wanted people to have abnormalities. And the study was restricted to male individuals. I wanted to put this slide there. Many people have seen this slide, but we've been talking about this circumscribed and commercial asbestos, and I wanted to show, especially the students, how does it look? When we talk, Dr. Yankeli will show a little one. This is a very dramatic one, but when we talk the asbestos, the commercial asbestos, the chrysotile causing these chunks of pleural thickening, I think the picture speaks many words, much more. So you see those chunks of pleural thickening, and this is what we call the circumscribed localized thickening of asbestos. That's what commercial, and that's what, when you talk to asbestos people, that's what people think in their minds. This is pleural thickening due to asbestos. And in Libby, you saw Dr. Blatt presenting that. Yeah, the kappa hopefully will be a very, very good one. I think. What we see in Libby is this different type of asbestos, which is the one that causes this laminar. We call it the laminar pleural thickening. There's a story between this laminar. We want to when you talk to asbestos people, asbestos people talk about diffuse thickening, and in terms of asbestos people, diffuse means is actually an X-ray diagnosis that requires that there is a thickening that blunts the one part of the X-ray. We call it the costophrenic angle, and the asbestos, the thickening will be related to that. So it's really more of a radiographic term, and the idea to call it laminar was to try to differentiate and telling the asbestos people, even within the asbestos, this is a new type of asbestos pleural thickening, and that's where we came with that laminar term. In order for this project, we devised, Dr. Brad and Dr. Levine devised a scoring scheme, which is not the scoring scheme that we have used for our papers. It's not the ICO-ERD. It was a different scheme, and that's one of the second points that I would like to discuss later, because it's a different way of looking at X-rays, and it may be one of the problems if we want to go ahead and publish this paper. The idea was to read the CAT scan at different heights in the chest. The CAT scan slices your chest and gets chunks of the chest, and we can look at the chest at different heights. So we took different cuts at different heights of the chest and divide each cut in four sections, and read each section for pleural thickening and for parenchymal. Parenchymal is the lung, and pleural thickening is the lining of the lung. And we devised a scoring system how to measure and add those parenchymal and pleural thickenings, and came out with type of a scoring system to try to put numbers that can be quantified and can be played for by the statisticians and the people who really knows much more than how to do these things. So we did clinical, radiographical with this scheme, and pulmonary function tests in this population, and we compared the two populations. And what I want to show you is the baseline data, which is the only one we have now. And then the study couldn't continue from them. But I think the baseline data is really, really interesting, and hopefully you'll see at the end where we're going with it. So we were able to have 89 people in the CAD cohort, the Libby people, and 57 of the insulators or the Sinai people. And this slide shows some of the characteristics of the people. Definitely there was a differences in age. The Sinai cohort was a little older than not much, but was significantly, statistically significant. There were no differences in body mass index, no difference in smoking history, looking at different ways of looking at it. So in those terms, the two groups were comparable. They were not significantly different. One of the things we found is that the distribution of pleural abnormalities was different between the two groups. And looking at after this discussion, you can see that both groups have both types. So let me backtrack a little. We divided the pleural findings between two big groups, what we call the circumscribed, which are those chunks of pleural thickening, and what we call the lamellar pleural thickening, which is this one that we see in Libby. So you see that both groups have both types. It's not that one is characteristics from the other. And actually, I was looking at both groups have more or less the same number of circumscribed pleural thickening. So there is circumscribed pleural thickening among the Libby people, but the lamellar thickening was much more frequent in the cart as compared to the insulators. And this was, again, confirmed our clinical suspicions. And that was statistically significant. So remember this, because we're going to come back to this difference. When we look at so remember I mentioned that we devised that scoring scheme to be able to quantify and to develop a score to try to measure the thickening of the lining of the lung, the amount of scarring in the lung itself. And when we look at those numbers, the scores were really, really not much different. Despite the type of thickening being different, the scores were not much different. So the circumscribed pleural thickenings were very, very similar. 9.7 the score and 12.7. That may be a little more in the insulators. I don't know why we didn't do significant differences in this study, but that will be in this table. That would be something to put on. The parenchymal score was very similar, so the amount of scarring in the lungs was very similar between the two populations. So we're talking mostly about pleural differences between the two populations. Symptoms and pulmonary function. And there we found significant differences in both. So the CAR people definitely had more cough, more wheeze, more shortness of breath when harrowing on level ground, and their very basic pulmonary function, we call it spirometry, was different, much lower in the CAR people as compared to the Szeinuk people.
The symptoms there's no comparable data of chest pain?
We didn't know. The Szeinuk people didn't have chest pain. Yeah. But that's one that we should definitely include, because that's a very good point. So again, so far we found differences in the type of pleural thickening, differences in the pulmonary function test, and differences in the symptoms. And that's what our study shows. So we've seen that the Libby-exposed individuals presented more frequently lamellar pleural thickening as compared to those exposed to chrysotile. And this replicates what the clinical experience was. The Libby-exposed individuals were significantly younger as the comparison group, the chrysotile people, but there were no other differences in BMI or smoking history. The Libby environmentally exposed people were more symptomatic and had worse spirometry results as compared to the chrysotile exposed people. And again, this corroborates our clinical experience and kind of confirms the hypothesis that we had when we put this study together. And you have to conclude that this would indicate that Libby toxicity, that Libby amphibole definitely is kind of more toxic than commercial asbestos. Less exposed people, significantly less exposed people, even younger people, and they have worse symptoms and worse pulmonary findings. What were the difference? There was one difference in age, but the only other difference in the two groups was the type of pleural thickening that was between the two of them. Libby amphibole people having more lamellar pleural thickening. So despite that, the pleural score was very similar between the two groups. However, there was still the difference. So is there any additional toxic mechanism involving in the pathogenesis of Libby amphibole? And to me, we've done like a kind of a 360-degree turnaround. And this is what I think is nice of this study is that, we saw it in the mice, we saw it in vitro, and now we see it in people. So I think this kind of shortcuts and really brings back to the same points that I think Jean has been trying to show, or Brad, but we see it really here. I think this is, I don't know, but I think this is the first study that we have two comparison groups that can look at these things. And I mean, to me, it's interesting. I think it's really showing what we've thought. Limitations, recall bias is always a limitation, but recall bias wouldn't explain differences in spirometry testing. So people can say, yes, these people remember better than the other people, but why the PFTs are different? That's kind of much more objective. There's no way to explain that via recall bias. One of the problems is that we are using a scoring system that is different than all the papers that we have published from the LERP. And I don't know if that can be a problem or not. And that's one of the issues for discussion. And yeah, I mean I think that was one of the points that Jean wanted us to discuss today. Is it so is it worth to really revise this thing and go use this? I think the data is very interesting, and it gives us the opportunity to really show two comparison groups, and this is what it is.